Jared, excited to have you here. A phenomenal topic, incredible speaker. Return to sports following joint replacement should be a lot of fun and exciting content, very applicable to our population. Dr. Wolfe is incredibly proficient and comes from an impressive pedigree, Georgetown Medical School grad, residency, then fellowship with Anderson Clinics. So we are very excited to have you. The floor is yours.
Well, first off, thank you very much for inviting me to speak tonight. It's a privilege. I hope you guys get something out of this. Before I jump into the talk, though, just give a little bit of background on myself, some information about me. So originally, I'm from the Western Pennsylvania area, grew up about 30 minutes north of Pittsburgh. As Ben mentioned, I then went and did my undergrad at Penn State. Then I moved down to the DC area in 2009 for medical school. I did that at Georgetown. While I was there, I signed up for something called the Health Profession Scholarship Program. Essentially, this is like a ROTC program for medical school. And then I've kind of bounced around the DC area since then. Walter Reed up in Bethesda, down here in Virginia at Fort Belvoir. While I was in the military, I was primarily in general orthopedics. So I did a lot of sports medicine type stuff. At Belvoir, we really had a strong influx of patients, especially from Quantico. So a lot of young Marines with shoulder instability, tearing their ACLs and things like that. Once I finished up with my time in the military, I decided I wanted to go back and do a fellowship to focus more on adult reconstruction, also known as essentially hip and knee replacement, which I did at the Anderson Clinic. And then afterwards, I was lucky enough to stay on and get hired on there. So I've been there actually coming up on about a year now. So 1 year into private practice. So my wife is also a doctor. She is an OBGYN at Inova Fairfax. And then I have 3 kids that are pictured here. So 9, 7, and 4. So what is adult reconstruction? So essentially adult reconstruction is all aspects of hip and knee replacement. So I do a lot of primary hips and knees, which are essentially people presenting with their native hips and knees, osteoarthritis, rheumatoid arthritis, essentially any of these diagnoses. At Anderson, we also have a large influx of more complex cases, second opinions, things like that, likely related to the fact that we have a fellowship. So I also do a lot of revision hip and revision knee as well. So these are all of the Anderson Clinic offices. Specifically for myself, I see clinic up here in Silver Spring, National Harbor, and Oxon Hill. And of course, I live over here in Burke. So there have been multiple days in the past year in which I have driven the entirety of the Beltway, which is fun. So on to the talk. So as I mentioned before, this talk is called Return to Sports Following Joint Replacement. One of the big things I'm kind of hoping to do in this talk is sort of demystify, a little of the things about what can be done with hip and knee replacements. The other thing that I'll try very careful to do is try to break down what areas are actually science and which areas are personal opinion. I think as orthopedic surgeons a lot, probably because we're a little bit arrogant, sometimes we have a tendency to take our personal preference as far as rehab or post-op protocols and act like it is dogma, and that's how it should always be done, when sometimes it's just simply personal preference. So the next couple cases are all patients that I saw in clinic, and some of the questions they asked me are sort of what drove me to think about putting this presentation together. So this first patient here, 49-year-old male, as you can see on his x-ray, medial compartment arthritis. He was at his pre-op appointment and he was scheduled for a left medial unicompartmental knee arthroplasty or medial partial knee. He asked me if I think he'll be able to go back to playing tennis after surgery. Relatively straightforward question. I think if you ask any orthopedic surgeon, most of them are going to be fine with this happening. A little bit of a more complex situation. 44-year-old man. This guy is 4 months after his knee replacement. He's doing well. He was a pretty avid runner prior to surgery, but now he wants to get back to running again and says he plans on training for the Chicago Marathon in a year. So in order to appropriately counsel this patient, I think we have to ask ourselves a couple questions. One, is it safe for him to do this? Is he going to damage the knee replacement or hurt something else? Also, in order to set appropriate expectations, I think we need to be able to counsel the patient, even if it's safe, what are the chances that he'll actually be able to accomplish this goal? And then finally, maybe the most complex case I saw as far as return to sport. So this was a 21-year-old D1 female soccer player. Unfortunately, she got diagnosed with, I believe, leukemia and was treated with high-dose steroids. You can see over here on the X-ray, the femoral head is completely died and collapsed, a condition known as avascular necrosis. Unfortunately, this can happen with high-dose steroids. The only treatment for this is essentially hip replacement. Now, luckily, she has beaten her cancer, but after her hip replacement, she'd like to go back to play not just a high-impact sport, but essentially a contact sport. So what would I tell her? But a better question is, does it even matter? I think we've all had the experience that a lot of times patients are just going to do what they want to do, no matter how we appropriately counsel or caution them. And I've seen this go both ways. I've had patients you do an ACL on, you tell them no cutting or pivoting. At 3 months, they're out playing soccer already. But I've also had some patients where you tell them it's okay to start doing activities and they're so nervous or anxious about hurting themselves that they don't push themselves physically. The other battle that we constantly find ourselves fighting is the battle of misinformation. Unfortunately, for all its positives, the internet is one of the biggest sources of misinformation for patients. More and more so, we're finding that most patients, prior to even seeing a doctor, have done some kind of research on what their condition is and what the possible treatments are. Unfortunately, there's also data out there that patients are more likely to believe their first source of information, no matter how valid it is. So looking at this study, about 58% of patients are going to look up information about their disease prior to seeing a doctor, and the vast majority of patients are going to look it up just using a search engine. And if we look at younger patients, unsurprisingly, this number is higher. Survey out of Forbes magazine looking at a younger generation showed that about a third of Generation Zers trust TikTok more than their doctor, and about half of them think that the information they're getting on social media is accurate and reliable. So just to test this theory myself, I went on Google and typed in, can I run after a knee replacement? And as you can see, the answer right there is clearly yes. The other battle that we have to fight sometimes is information getting sensationalized by the media. So I think most of us are aware that there have been a couple professional athletes recently who have returned to play after getting either a hip or knee replacement. Now, if you think about the total number of professional athletes, these numbers are quite small, but they do find their way out there. So Isaiah Thomas famously had a hip resurfacing, went back to playing basketball. One of the more recent ones, Lindsey Vonn, had a partial knee replacement and went back to skiing. Although unfortunately, since that time, she's run into some other orthopedic issues, which have been keeping her out there. And then if we look at kind of the original, Bo Jackson had a hip replacement and was able to return to playing baseball. So enough about the internet. What do the real experts say? And do we actually have any information to support this? So this is going back a little bit. So some of what we're showing here is I want to show sort of the transition in what we think is okay. And we'll talk about some of the science and some of the changes in technology involving hip and knee replacements that are likely driving some of this change in expert opinion. So this was a 2007 web survey. So it was sent to the Hip Society, which is HS, and then AAHKS, which is the American Association of Hip and Knee Surgeons, which is sort of the National Society for Adult Reconstruction. So essentially all they did was they asked the surgeons, they gave them a list of sports. They said, would you allow patients to do this? Would you allow them if it was something they had previous experience with, or would you not allow it at all? So in general, in 2007, people were completely okay with low impact activities. Intermediate, we saw it start to trickle down, and most people felt high impact activities such as any type of contact sport, baseball, running should not be allowed at all. Now, there were a few, we'll say, strange discrepancies here. Apparently, they felt skiing was significantly safer than snowboarding, and also a pretty noticeable difference between singles and doubles tennis as well. So I think when we look back historically on what patients were being told, we need to look at a little bit of context regarding hip and knee replacements. So not to get too technical, but when we look at the components involved in a hip replacement essentially has 4 components. It has a metal stem that goes in the femur. It has a metal hemispherical shell that goes in the pelvis or acetabulum. It then most commonly has a plastic liner in the acetabulum, and then either a metal or ceramic head sitting on the femur. If we go back in time to the 1990s, the most common plastic being used at this time was non-highly cross-linked polyethylene. So when you looked at the design of a hip replacement, the metal or ceramic head was articulating with the plastic. Since this plastic was much softer than the metal would cause pieces of the plastic to shed off into the skin or surrounding soft tissues. Unfortunately, this triggered an immune reaction. The body's white blood cells would come, they would release a bunch of enzymes, and this caused a lot of destruction to the surrounding soft tissues and even could cause significant bone loss. So if we look at studies from that era, looking at non-highly cross-linked poly, we see that the main reason we were doing revisions was for this polyethylene wear and then loosening. Especially if we look more than 10 years out, essentially eliminating some of the infections, we see that this is one of the biggest things that surgeons in 2007 are concerned about. So the thought was in general that if you're doing a high impact activity, the hip is moving more, therefore you're likely shedding more particles, which is going to lead to this happening quicker. This is just an example of polyethylene wear with significant bone loss, and now the cup has completely come loose. Now, fast forward from the 90s to around the turn of the millennium. Around the turn of the millennium, we developed a new way of processing these plastic parts, and we developed something called highly cross-linked polyethylene. Now, initially when it was developed, we were able to look at it in a lab, and at least in a lab, it looked like the amount of particles it generated and how quickly it would wear away was substantially slower than the previous polyethylenes, which in theory would make this osteolysis less likely to happen. We have now recently begun seeing our 20 and 25-year data on this new polyethylene. And the good news is it looks as good in real people as it did in the lab. So this is a study in 2023 out of the Mayo Clinic, looking at all their cases using highly cross-linked poly, and they had 0 cases related to the polyethylene wearing out. Similar study, this one out of University of Nebraska. Once again, 20-year data, 0 cases of the poly wearing. And these numbers here are just to show that the wear rates were extremely low when they looked at them. So if one of the major causes of revision 25 years ago is no longer at issue, then maybe a lot of these concerns about the risks of high impact activity are no longer valid with our modern implants. So a couple more surveys here, and this is really just here to show sort of the paradigm shift. How as we start to get this new data, we start worrying less about polyethylene wear. In general, most surgeons start to feel more and more comfortable with their patients doing at least high impact activities. So this was a 2016 survey of the British Hip Society. Now over half are allowing jogging, still pretty low rates overall of allowing contact sports though. 2020 survey, this time the European Hip Society. Once again, we can see the numbers slowly increasing. This is just telling you the weeks, how far post-op they would allow them to do it. But once again, you see jogging is now up to 75% of people or surgeons thinking that it's an acceptable activity after a hip replacement. And this is kind of just the most recent one. This was a world export panel. And you can see in general, once again, they don't really have any specific recommendations for limiting patients after a hip or knee replacement. So promise you that's the last survey that we'll go over. So now the question is, do we have any hard evidence to help support some of this change in opinion, or is all just gestalt? So I think there's a couple questions that we need to sort of ask ourselves about returning to sports if we're able to appropriately counsel patients. So first off, we've kind of already alluded to that our counseling doesn't always matter, that sometimes patients are going to return to sports even if they were told not to. So the first question I would say to ask ourselves is, do patients return to sports? So this was a systematic review. So essentially what this does is it takes a bunch of data from different study and pulls it all together. Unfortunately, and you will see this is a kind of a common theme among a lot of this literature, is a lot of this is retrospective, sort of just observational, essentially just asking patients, did they return to sport afterwards? So pretty high rates of bias in this. And another struggle we have is that since most patients getting joint replacements are older, the data does tend to be skewed to that population, which is a population also less likely to return to sport just due to other comorbidities. So after TKA, if we break them down into low impact, intermediate, and high impact, you can see the rates down here, obviously tapering off somewhat as we get to high impact. Partial knees, kind of similar numbers, once again tapering off as we get towards high impact. This was an umbrella review, kind of similar thing to the systematic review. Once again, these are just ways of developing large numbers of patients. And after going over the data from the review, the authors came to the conclusion that most people's recommendations are based on a theoretical risk of trauma, essentially somebody getting hurt playing the sport and getting a fracture or other sort of catastrophic complication. However, they noted that none of these studies at any point showed that participating in these sports increased their risk of having these complications. This is a similar study, except looking at total hips. Once again, we see pretty good return to sport rates with low impact, decreases a little bit as we get into high impact activity. Kind of similar thing. One of the big things, though, that confounds a lot of this is why don't patients return to sports? And I think it's also important that we ask patients when the last time they did the sport was. Patients who were able to do running, for example, within a year of getting their hip replacement are far more likely to return to running than patients who haven't ran for 5 years, even if it is primarily related to their hip arthritis. So if we look at this here, this is looking at patients who had a unilateral total hip, and it's looking for the reason why they didn't return to sport or they did not return to sport at the same level. And you can see primarily these two bars, if you look at over here, and those make up almost 40% of the patients who didn't return to sport, did not return to sport for reasons that essentially had nothing to do with their hip replacement. So they either weren't motivated or they had pain in other areas of the body, back pain, knee pain, etc. The second question I think we have to ask is, if they do return to sports, are they safe? What is their chance of either increasing their risk of a revision knee or hip, or sustaining some other type of injury? So this was a 10-year follow-up looking at 210 patients who were returning to sports after a hip replacement. 70 were doing high impact and 140 did low impact. Now, in this one, the high impact did have a slightly higher increased rate of revision. However, this study was done with the previous polyethylene. So this may show some support to the guidance and counseling that patients were being given in the late 90s, early 2000s. Looking at rates of loosening after ones, this study found that there was not really any difference. Once again, generally small study sample. This one specifically looking at polyethylene wear, without getting too much into the science. Once again, 100 patients, wasn't able to show that activity level had any impact on polyethylene wear in these patients. Now, shifting gears here a little bit to try to look at some specific sports, either focusing on sports that are very common for patients to return to, or maybe trying to focus on some that are a little bit higher risk to see if we're able to see a difference there. So this one was specifically looking at judo. So obviously a contact sport. So 38 patients who were doing judo prior to getting their hips and knees done, 29 returned after, and they had no major fractures or dislocations in this population. Looking at a return to cycling, once again, pretty high rates of return overall. But if you look at return to skiing after total joint replacement. So this was a survey of 763 patients. So if you see, about 80% were skiing prior to surgery. Most of them were able to return afterwards, about 60%. But once again, like I said, this is a common theme here. If you look at their reasons for not returning, a very small percent was actually related to the surgery itself. And there was a lot of other medical issues and things that played a role when they chose not to return to skiing. One of the most common sports that my patients are playing nowadays is pickleball. And this had a pretty good return to sport rate, once again, 72%, and that does not account patients who did not return for non-joint replacement reasons. So in order to counsel as well, I think it's important that we understand what the sport-specific injury risks are. Obviously, outside of the joint itself, having a fracture or other type of injury in the same extremity as a joint replacement can cause pretty significant medical issues. So this was just looking purely at the 2020 US population data. And the big thing that we're looking at over here is rate of injury per 100 participants. Obviously, contact or collision sports have a much higher rate of injury. And you can see that here with football, martial arts, and soccer significantly leading the way as far as risk of injury. So conclusions. So I think one of the biggest takeaways here is that this is an area that's pretty hard to study. We don't have randomized control trials. We aren't able to do hundreds of people in each sport where we specifically select who and who doesn't return to sports. So we're dealing with data that's mainly level 4 and level 5 studies. Polyethylene wear is likely no longer an issue. So as I mentioned before, a lot of the concern when I was in residency, when people were training 20, 30 years ago, is that any type of high impact or increased activity level would cause the plastic piece or the polyethylene to wear out quicker. At this point, I think we can safely say that that's no longer a problem, or at least it's definitely not a problem the way it was before. However, I also think it's important to note that 20, even 30-year data is a little different than 40 and 50-year data. So when we start talking about joint replacements in people in their 20s, hoping to have the implant survive for 60 years is a completely different aim than it is in somebody who's a little bit older. Periprosthetic fracture is still one of the most devastating complications. There's pretty substantial evidence out there that in any patient who has a periprosthetic fracture, the impact on their livelihood, their function, all of these things is quite substantial. So this is obviously something that we want to try our best to prevent in any way we can. So what do I tell my patients? So I think there's a few things here that we can say pretty definitively. There's some things that we can say are most likely true. And then there's some things that require a very, very long clinic conversation. So low and intermediate impact sports are safe. I don't think there's any doubt about that. And actually, if you look at some of the data and studies out there, patients who return to low and intermediate impact sports after joint replacement, in general, have higher quality of life, have higher patient-reported outcome measures than patients who don't. Now, there's probably some selection bias here. So patients who choose to do no physical activity after joint replacement likely have more medical comorbidities or other orthopedic issues preventing them from doing that. With the new polyethylene, I think that high impact non-contact, so running, tennis, things like this, are very safe. I don't think we really have to be worrying about these activities increasing the plastic piece wearing out, increasing any type of revision rate. It's important, though, that we talk with our patients about what the chances are that they'll be able to do this, though. As I mentioned before, one of the biggest factors going into it, and anytime I have a patient come into the office and they tell me they want to return to run after a knee replacement, I think the first question to ask is, when was the last time you were able to run before this? If they were doing it in the past year and it's really just tapered off in the past 6 to 9 months and it's almost all related to the pain they're having in their knee or hip, then I think their overall rates of return to run are going to be very high. If we have somebody with multiple other medical comorbidities or somebody who hasn't been able to run in 5 years, even if it's from their knee replacement, I think their odds of getting back are going to be much lower. And while I tell them it's okay for them to try, I also do try to caution them that the likelihood of it happening is much lower. And finally, kind of the hardest conversation involves patients playing any type of contact sport. So if we look purely from a joint replacement standpoint, the patients probably can go back to a contact sport. I don't think that there's any evidence that the sport itself is going to increase rates of damage to the implant or plastics. However, engaging in these sports we know does increase the rates of fracture or other serious injury. And a fracture around a total knee or total hip can have devastating lifelong complications. I also have a long talk with my patients because a lot of them come in being aware of Lindsey Vonn or these other famous athletes. And we also have a talk about sort of what their life goals are and kind of at what level they're playing the sport. It's very different to risk serious injury to return to a sport after a hip replacement when you're making $10 million a year versus doing it just to have fun and play in your rec soccer league. So returning to those sort of original cases I talked about, just kind of walk you through sort of how I talk with these patients. So in the man scheduled for a uni, he asked me about playing tennis. I essentially told them that would be absolutely okay. You can return to tennis. Your chance of being able to do it, as high as 80 or 90%, especially given his age and the fact that this was a sport he did beforehand. 44-year-old male who was an avid runner. He had been running in the year prior before his knee really started bothering him, and he had completed a previous marathon about 2 to 3 years beforehand. So since he was now 4 months out from surgery, I told him I was okay with him starting to run again. However, I did caution him that a marathon is, quite a long distance and requires a lot of training. So while I thought that he would definitely be able to run again, it's hard to guarantee that he would be able to get to the number of miles a week that he would want in order to train for a marathon. And finally, the D1 soccer player. We had a long conversation. This is one of those clinic appointments that took a good 20 or 30 minutes just discussing this. I essentially cautioned her that while I would be okay with her running again, I think she really has to consider, the risks of returning to soccer at that high of a level. And we discussed that if she were to have a fracture or other serious complication, it could have lifelong consequences. Thank you very much. Hope you all have a great evening.
We got some questions pouring in already, so let's if you're open to it, let's fire away on those.
Let's do it.
All right. So John asked, while the X-linked polyethylene seems to be, the cross-linked polyethylene seems to withstand impact better. Do you have any data on the metal parts loosening over time with higher impact sports?
Yeah, it doesn't seem to be. So when we look at sort of the aseptic loosening, doesn't really seem to be a problem. Now, if there was anybody who was using sort of older implants, so especially with knees, if they're cemented, that would be where I'd have a little bit more worry. Now, we have over the past probably 7 or 8 years, younger patients, even in the knee population, are now getting cementless implants. So in cementless hips, which are sort of the gold standards, and cementless knees, which are starting to become more and more common, especially in younger patients over the past 5 years, they have a sort of 3D printed porous material that the bone actually grows into them, and they essentially become biologically incorporated. So in theory, once that process happens, unless there's a fracture or something, they shouldn't be able to loosen. So I guess to answer your question sort of a little convoluted way, anybody with a cementless implant after 4 months, and that's just because that's about how long we think it takes for them to ingrow, think there's very low risk there. If somebody had a cemented knee, I would worry a little bit more, but those are typically the older patients who probably aren't returning to high impact at the same rate.
And then the next question, high level sports require optimal proprioception. If you have a patient coming in for potential TKA, would that influence your choice to spare the PCL to maximize proprioceptive input post-replacement?
So I am a big proponent of preserving the PCL in every single case because I think there's a lot of benefits with you look at the sort of kinematics of how the knee moves and stuff. So since I do it all the time, but yeah, I think it would be beneficial. I guess is the short answer there, but that's kind of my baseline is to do it.
I'm going to throw one in there too. Are you seeing a particular mechanism of injury for the fractures around the implants?
Yeah, so luckily I have never seen a periprosthetic fracture yet outside of somebody with essentially osteoporosis. So, that's why we get into those. A lot of these things are theoretical. So, because, we talk about at least in young, healthy bones, so like in that 21-year-old, I'm worried that she's going to have a periprosthetic fracture around her hip on the left side, but we don't really have good data that if she were to fracture anything, that she's not just as likely to fracture her other femur. So yeah, all the periprosthetic fractures that I've seen and treated have been in really osteoporotic bones. So 83, 84-year-old women, ground level falls. So that's typically the mechanism that I'm seeing.
Yeah, I was trying to think through that maybe it was like a torsion mechanism or a contact injury or something like that. And just because the stem of the implant was holding it well, that the bone was the part without the stem was maybe the easiest place to break or something. So curious to hear that mechanism. Glad to hear it's not as common as it looked.
Yeah, you're probably right though. In the osteoporotic bone, it's typically torsional, and then you get sort of a spiral fracture around it. They are a little bit more prone to break around the implants than sort of the other area of the bone, just because even though we use titanium, which is sort of the most similar as far as elasticity to the bone, there is still a modulus mismatch, and that modulus mismatch creates sort of a weak area where they interact. So yeah, you typically get
Makes
that
sense.
torsion and then a spiral fracture at that interface.
Yeah, so I would think someone who's doing a contact pivoting cutting sport might be even more prone to that. I was surprised when you were like, yeah, singles tennis, no question. I had heard, at least in the past, that singles tennis much less likely than doubles tennis for that reason. Just a lot of cutting, pivoting, change of direction real fast.
Yeah.
Okay. John Cicerella asks, if a running marathon is the goal, does how they train for it matter? I can see how, for example, a lifelong runner would be able to complete a marathon on 20 miles per week over 6 months, but seasons of high level marathoning is a different thing entirely.
Yeah. I mean, I've had, and also I will say, based off, and this is a little bit anecdotal, I don't have direct comparisons. I do think it's a little bit different sometimes on a hip versus a knee. So my patients who want to go back to running marathons, if it's a hip, normally they seem to be a little bit more successful, and they normally seem to be able to handle the higher mileage better. On knees, we do a lot of talk about cross training and other things like that to try to, build up endurance and build up your aerobic capacity without 40 miles a week. Just because I think the way the knee replacement works, some of the kinematics about the knee get changed as we put the replacement in. And I think it's a lot harder on some of the surrounding tendons and soft tissue structure trying to ramp up the mileage that high. Now, once again, that's a little anecdotal. I don't have pure science to back that up, but that's just been a little bit of my experience.
And I also wonder the underlying mechanics that led to it in the first place. If those haven't been addressed at all, then, it either goes up or down the chain potentially.
Yeah, no, that's true.
All right, another question. Is there a role for return to sport testing for THA or TKA, such as what we do for ACL reconstruction? And if so, what would possible parameters be from your perspective?
That's interesting. So I think the short answer would be yes in sort of select patients. Now, normally with essentially like two exceptions that I'm thinking of, for example, that 21-year-old, most of the people I'm looking at are sort of recreational athletes. So, getting into returning run, just playing in your neighborhood tennis. I don't know that we necessarily need some kind of formal testing for that. But I do think that, especially if we're looking at somebody getting into a contact sport or something, we need to make sure that they have appropriate proprioception and they, if they fall, they're going to be able to land correctly and sort of these other mechanics. Because I think if you get them back to sports, especially a high risk of injury sport too early, you're going to increase their likelihood of injury. So yeah, I think I would definitely, I don't know specifically, that would probably be something where I would, set up a phone call with either their athletic trainer or their physical therapist and kind of have a group conversation about what that looks like. But I think in those few select patients, it could definitely have a role.
Another good question. The risk of not loading bones over time, especially if you're perimenopausal women, how does that enter into your conversation with them about impact sports?
Well, I definitely think that's one of the reasons why, low and intermediate at impact definitely do better. So I definitely recommend that all my patients engage in some kind of sport. I typically tell them I want them doing some kind of aerobic. I was like, whatever aerobic you like the best. You want to walk, you want to elliptical, you cycle, swim, any kind of that. And then you need to do some kind of resistance training. At the end, there's data out there that some are better than the others. But to me, my biggest concern is always compliance. So if there's something they're willing to do, even if it's not the single best one, I'd rather have them get in that and then be more likely to, be compliant with it.
Fantastic. Any other questions from the crew? All right, Jared, fantastic. Loved it. A topic that sounds like has made a lot of change in the last, 10, 15 years. So good to hear that the rates of wear have gone down. And I think it's a good conversation to have. For the team here, I'd love to get them your contact information. Was that up on your last slide? Did you have that there?
I did not have it, but I'm happy to give out my why don't I shoot you an email with my I'll give you my cell phone and my email address and stuff. And then if after other people listen to this, if there's any other questions people want to shoot me, I'm always happy to send out another email or answer anything that comes up.
Perfect. Yeah. I want to make sure that they're able to contact you if they've got candidates for surgeries. And actually that's another important question. We talked about it before we started recording, but would love to hear for those who are on the call and listening afterwards. Ideal world magic paintbrush, if your schedule was full with X types of patients, what would those be? Who are the patients you would love to see most?
Yeah, so in general, I'm loving hip and knee replacements. So anybody who's kind of, on that level. I also do a lot of very happy always to do, second opinions. So I end up seeing a lot of second opinions. And, a lot of times the answer is, yeah, you're still just working on the rehab and this is, completely normal. There's nothing wrong here, but no, I'm happy to kind of see that type of stuff. And then, like I said, I'll send out my, my email and cell phone. I am extremely responsive to text message. So, especially if anybody has any, quick questions they ever need to fire off me, go ahead and shoot me a text message. If I'm not physically in the OR, I'm normally responding within 15 to 20 minutes, sometimes to my wife's annoyance, but
that's fantastic. Yeah. Having that direct line of communication with colleagues is awesome. So we'll definitely have our team get that contact information and probably take you up on it. So I appreciate your time. Thank you again for your expertise, for your willingness to share on a Tuesday night. Thanks for all who attended and for those who are watching the recording, and stay tuned for the next one. Thank you, Jared.
All right. Have a great evening.
Take care.